Topic is something which most of us were really looking forward to. A lot of learnings is expected. As Rajlakshmi mentioned, we have two Indian faculty. I'm so glad to introduce Dr. Pal. She has done her PhD based on the experience of cancer patients at University of Helsinki, Finland. And she is a teacher, researcher, and deputy director of WHOCC in nursing research and education at the Institute of Nursing Science and Practice at Paris University in Austria. She has a lot of achievements. If you just Google it, it's there everywhere. But I think what interested me most is her work in the topic of spiritual care, because that is something that we rarely talk and deal with, although we know that it is very important. Many times we get stuck how to put it in words or how to explore or how to provide that particular care. And I think she led the process in 2021, resulted in the publication of EAPC white paper on multidisciplinary education for spiritual care and palliative care. I just wanted to highlight that part because that comes very, very relevant in our setting also, like in any other place in the country. Thank you, Dr. Pal, for agreeing to be a part of this program. I think this is the first time we are interacting or having a session from you. And thank you, Dr. Roop, for introducing Dr. Pal to our training group. Welcome to the program. And Dr. Roop, I think most of us in this group is familiar because you might have already heard from Dr. Roop during your foundation course, at least many of you. Dr. Roop is an epileptologist and neurologist in Hinduja Hospital, Mumbai. And he has done his work in ELICIT, which is an interdisciplinary task force of intensivist palliative care physicians and neurologists for end-of-life care in India. Welcome, Dr. Roop, for the program, and over to you both to take it forward.
Right. So I'm really pleased to be here again. And I think the first talk is Dr. Pal's.
I think so. Yeah.
Yeah. So I think let's not waste any more time. We'll keep time for discussion at the end.
Yes.
Go ahead.
Please go ahead.
Yes, hello and good evening to everyone. I am also a little bit excited to be part of this training, and I hope that you are not very tired. I understand it is quite late in your part of the world. It is still afternoon in where I am currently located. Indeed, there is the topic of spirituality, which Roop, Dr. Gursahani already told that, in India, we think something different when we talk about spirituality. So he put some pressure on me, and I will try to make a case that I think that we as universal human beings actually have quite similar spiritual needs worldwide. So let us see where the journey takes us. And I will share also my PowerPoint. I hope that it will. Can I do it? Yes, I can do it, I think. And yes, I was asked to speak about something that hasn't been really studied, which is the spiritual care in neurodegenerative illness. And I just want to make a case for something that we, together with Roop, called When Needs Are Not Met, People Lose Faith. I have put some questions here. So just like how to approach spirituality in healthcare, because spirituality, excuse me? Okay, there's some echo. Okay, so someone has to put their microphone, please.
Yes, I request all participants to please stay muted while Dr. Paal is talking. Yes.
Yeah, otherwise we cannot hear anything. So yes, so what do we understand in healthcare in general when we speak about spirituality and spiritual care? Because spirituality is just theoretical concept, and the meaning of it actually takes place when we now something happens here, which I don't want to happen. I have to go back, but I don't know. Oh no, I can go only forward. So let's go back. Yes. So I will leave it like this. I will make it a little bit so that I have control of what is happening here. And, or let's try once more. Sorry. Yes, so what is known about spiritual aspects of care? It's the area that gets lost, very little money for research. So we have very poor evidence actually. And sometimes when we have evidence, then also some, the way that the data has been dealt with is somehow, I call it wonky. So it's difficult to use it really. There are many questions like that if it's done correctly and so on. And so also for healthcare providers, why we need to speak about and think about our own spirituality, why is it important also in our organizations? And of course, for people who are from medical field, are there any tools that we can assess spirituality? So that I come to that at the end. And here is the definition of spiritual dimension. And spiritual dimension has been actually part of the WHO concept already since the WHO was introduced as a big health arm of United Nations. And it is something that implies to a phenomenon that is not material in a nature, but belongs to the realm of ideas, belief, values that have arisen in the minds and the conscience of human beings. So it's not only in health and sickness, but it's in everything that we do. It is the essential part of giving meaning to the things that happen to us. And so it is, of course, gets its meaning when we self-reflect, but also when we act in our social and cultural surroundings. And it is something that, according to WHO, plays a great role in motivating people's achievements in all aspects of life. So the question is, so why do we do what we do? And sometimes we even don't want to ask this question or pose this question to ourselves. And yes, spirituality, as already in the introduction was mentioned, we say that it's not always a religious part in our white paper that we proposed for EAPC. We say it's a universal, deeply personal and individual dimension, and it goes spiritual care goes beyond cultural beliefs or religious practice to encompass the unique capacity of each individual. Yes, I have dealt lots, or I have put lots of effort into understanding how can we educate healthcare providers in spiritual care, and normally this is somehow understood as that it is our individual task to learn how to be more spiritual and how to provide spiritual care. And indeed, self-reflection seems to be a very important thing here. First step, really, to understand what spirituality means to me. And I also, as I already said, that it's a theoretical concept, and this can be music, it can be art, it can be dancing, it can be being with other people. So it can be some sort of spiritual practice, also rituals that you do daily and that give meaning to your life. So that are important things in your life. And this needs work, this part. And some people say that, well, I use pictures and text to understand what my students understand as spirituality. And I recently had a student, she said that her room is empty, so there is nothing. So when she thinks of her own spirituality, she's not religious. She even tries to deny religion in her life. She's a very pragmatic person. And so only after reading the paper, which was compulsory, she started to understand that it is something individual. And then she said that this room now becomes my opportunity to build my spiritual home, kind of. So it is possible with small things also to understand the perception or change the perception of what spirituality is. But healthcare professionals overwhelmed with their work need organizational support. So it's not like this that we send people for 6-week compassion course or meditation course or yoga course, because all those, and then measure if they reached some new level of spirituality. That would be, of course, wonderful if they, but we speak here about practice, practicing something, and you're never ready with a practice, you know, so it doesn't work like this, that the 6 weeks course gives you immediate results. So it has to be little chunks at workplace that help. This is just, I don't know how to stop this jumping away, but so it's some little chunks really at organizational level that that organization provides space to build the spiritual capacity also in teams, so that it is an organizational effort, that you have certain amount of resilience, for example, in your workplace, but not this kind of rigid resilience that breaks people at the end and nobody returns. Because at least in Europe, our organizations are very proud of workers who are so resilient that they do everything despite what is there, how many workers are there, they get everything done. But then at the end, they are burnt out and they leave their workplace and you never get them back anymore. So indeed, it is not this individual that go and get spiritual and change your attitude and something like that, but it's organizations that can help a great deal here to support our healthcare workers first. And from this organizational support, actually this kind of capacity to provide spiritual care actually emerges. Currently we have, I call it 3 levels of void. People say that, yes, I am not religious and or spiritual and it doesn't matter. But in particularly when a patient says that I am not religious, neither spiritual, when they deny it, then behind this denial can be a very strong signal actually that they need support, in particularly in this area. So it's just like the no is not the definite answer. You have to see it in a relationship or in a relational way. So what spirituality in palliative care or spiritual care means is actually being mindful of oneself, one's fellow humans and the world. And this is, I use here Paul Ricoeur's like hermeneutical worldview actually, which is that first it is the first step is self-understanding, then it's the communication between the world and man, or man and man, so between 2 people or more people, and then there is this referentiality as well. So this is the negotiation between man and world. So what's my role in it and how I am perceived and things like that. So the communicability is a very important dimension that I always tell to my students, because when you have only walls around you and nobody around you, then you don't know anymore what's your worth, what kind of human being you are. And in particularly patients who are in a vulnerable situation may lose the understanding what kind of people they are, and that they are still matter as individuals. And that's why this kind of communicability, this kind of exchange and being there, maybe doing nothing, but just like being there, and with this act of being there, just demonstrating that you matter, you can actually empower patients also who are in a very, very vulnerable situation. This said, so now what about neurodegenerative disease? As I said, there is very little evidence, but we looked a few years ago into literature that is out there. Now there is a little bit more, and we came up with this kind of it looks like very rigid structure, but we put it like in the beginning when you have the diagnosis, then First of all, because it's a long process, if you get the, except of stroke, that we will discuss this later, but with many neurodegenerative conditions, it's a long process. So in the beginning, it seems that the very patients and caregivers need this kind of initial talk, what to expect. Then during the illness course, you have to monitor the changes. And one big challenge is to prevent the isolation and demonstrate belonging. So which happens because people are ashamed of their conditions, and more ill they become, they withdraw from life, and so they actually suffer from loneliness. And this is also loneliness. It's not the social isolation, but it's the loneliness that can occur also when you are surrounded by people. And this makes us sick. We have strong evidence on that as well. And then in between, many things happen. Let's just have a look at those 6 categories that we came up when we looked at the literature. At the very end, maybe in palliative, in neurodegenerative populations, this legacy work at the end of life, it has to occur earlier than this average 12 or 18 days that people have in palliative care worldwide. So because they are not anymore, they cannot anymore express what their wishes are, but it's very difficult to find this kind of moment when to speak. We are doing research into this with Parkinson's patients, and they say that, well, I'm not that far yet, or I am too young to think about end of life. And so this kind of legacy work, which is just like proposed, and but for example, we have healthcare chaplains in Europe can do, seems to be very helpful. And there's some evidence on this from United States also, for example, that people with Alzheimer's benefit from this legacy work. But yes, so let's look at the dimensions in the between. There is why I think that the spiritual needs or this request for meaning is the timeless and universal thing. This just like, because we need to understand what is happening and why this is happening to me. And there is now this kind of new field of science, which is called spirituality and neuroscience. And they have started to, without actually looking at the earlier theories from theology, philosophy, or psychology, they now make up their own theories based and try to locate spirituality and religiosity in the brain. But here we have a nice picture from Michelangelo, where you also have this brain, so before neuroscience and spirituality occur, already artists and all other people understood that our religiosity and spirituality also has something to do with, and the way how we live our lives has to do something with our brains. And of course, when the brain degeneration happens, also the spiritual and religious perceptions may change, and also medicalization has a big role in it. But I think it's more Roop's specialty here, so I will not go into that, but I just mention what I, as an anthropologist, find totally fascinating is the worldwide, this kind of understanding that if you have some kind of palsy, shaking, some episodes, that it's across the world, worldwide, we have this kind of myths that people try to explain this kind of falling ill, falling into the sickness with supernatural factors. It is understood as a punishment, divine testing, evil eye even, and this is until nowadays. So because we have very little neurologists, people have difficulties to find a correct diagnosis. And that's why then they look at the different resources, and usually clergymen, but also spiritual healers from many communities then try to explain these conditions, and this kind of therapies that then follow are very much based on cultural beliefs and traditions. And I never been to India, but I think that you also hear from this kind of practices. One of my colleagues told that people who have some kind of neurodegenerative disease, and she comes from India, for example, can go to a monastery, and if they are able to swallow a goldfish, then they will survive, but if not, then they will not survive. So this kind of myths and tests and trials are still very much prevailing in the worldwide. So we have personal values and beliefs, and what affect those personal values and beliefs are poor, limited understanding of illness, when it's not clear that what is happening to me, why is it happening to me? And that's why this kind of essential talk, also finding a reason why I have fallen ill, is very, very important for patients to cope with their disease. And if they feel endangered existentially or have some kind of uncertainties in this regard, because in neurodegenerative disease, finding a diagnosis can last for many years, actually. So their overall situation worsens, and their illness experience, we see it in our Parkinson's patients. They just want to talk about the suffering that they have gone through. They don't want to think about death and dying or planning for the end of life, but they just want us to reflect on what they have suffered so far. So then there is this kind of self-perception, and what happens is that you notice that your body is failing prematurely, and then you look for answers. Why is this happening to me? And these why questions are always strong indicators for spiritual needs also. And it is okay to say that I don't know why, but let's think together or discuss this. So that would be my suggestion always. Then, yes, there is the bodily deterioration and responses to care. And at some point, the responses to care are not so, or medications are not so good anymore. So the care part comes in, and palliative care in particularly. And then if you realize that you're now nearing your death, actually, then there is also a need to talk about this. And people seek different ways to discuss death and dying because it's such a strong taboo. Then they might talk about their dreams, for example, or use some kind of metaphors or this kind of awkward experiences in the nature. And with that, they want to communicate that they think that they are nearing death, but they cannot say it so directly. So our communication is a little bit difficult in this sense as well. And then there are unmet needs. And the problem with unmet needs is that people define needs. And of course, it would be wonderful when we would all be so well trained that if we have needs, that then if we cannot change those needs, then we change our mind. But not all of us are so strong. And then when people seek for solutions, and if they don't get solutions from their clinicians, then they lose faith. So that's why it is necessary to talk about the things that are really at the top that for these patients, and not to ask like kind of long list that what you all need, but really ask what is the most important thing for you right now, and how can we help, and go from there. So it doesn't have to be complicated, and I have sufficient evidence from my students that when they go to the patient, and instead of asking how are you today, ask what is the most important thing currently for you, then they get an honest answer, and they can actually do something about it. It's either, it can be like, I couldn't sleep, so okay, we organize so that you can sleep now, or can you find all my things because I'm leaving the hospital and I am distressed, so just check with me. Very helpful. So all this kind of very, very simple situations, nothing complicated really. And I say that the spiritual needs quite often are about unfed cats and dogs and unwatered plants. more often than actually big theological questions, so we shouldn't be afraid to ask actually, and proactively getting involved in these matters. And really, once more, these questions: what is the most important thing right now, or what you need right now, and how can I help? And then there are lots of, because this well-being dimension is, of course, directly linked, or overall health-related well-being is now an area that has been studied, and we indeed have also some tools that seem to be culturally appropriate as well, to be used in different locations. But also, this is something that changes, and I'm not sure that you can use for a big cohorts this kind of things, but not when you work with patients. So because yeah, this is because of the referentiality again. So what is happening currently in your life, and it can be in the morning, it can be different than in the evening, or depending how your medication works, it can change during the day. And usually when people visit healthcare professionals, if it's planned visit, then at least neurological patients, many are at the peak of their well-being, and when they go home, then they are at the low point of their well-being. Then group support is very important, and this is in particularly just understand that I am not alone in this situation. I meet people who are in a similar situation, and sometimes this is also a very human thing. In German, this is called it's an evil word, it's a Schadenfreude, you use it in English as well. Is that you understand that I am not the one worse off, the others are even in a more worse situation. And this can be also an empowerment, but it doesn't have to be, of course, the Schadenfreude. It can be also learning from each other, knowing what is going to happen to me, and to get some answers from people who are in a similar situation. And it is also important for the caregivers. For some caregivers, this kind of group supports can be very, very helpful, because just because they can leave the house and have time for themselves. So, and there is more behind it, but just my message always is that it is this kind of all health professionals are to provide opportunities for patients and families to express their spirituality, and then just to see that where the journey goes. And it doesn't have to be something very exhaustive and very long. It is just something very brief, and patients really, really appreciate it. Then conversation, because I said about the tools, and we don't have really good tools to measure spirituality in patients with neurodegenerative disease. So, but even if we have those for cancer patients, my opinion is that yes, use the tools, but a conversation about spirituality is as crucial, and it is crucial to establish a therapeutic relationship with your patients. And this prepares the ground for screenings and assessments that take place in parallel, but cannot replace the conversation. Now I stop here, because I could go on and on, but I say that listening is learning, and I thank you for listening, and I am, of course, happy to answer your questions. I don't know how we do it. So it was very rushing through all the things, but there is, yeah, as I said, the evidence is not very, very good. And I am not even sure if we can measure the spirituality really. So maybe we have to think here, have a more narrative approach to this area, this important area in healthcare. Yes, thank you very much.
So
Thank you, Paal. Dr. Roop, would you want to take questions related to this now, and then go ahead with your?
Yeah.
Of course. I mean, there is some amount of discussion. In fact, I have questions
Yes.
for Piret. So,
Yes.
so one question that I've always had is, as patients are deteriorating, and obviously it becomes difficult to communicate with them cognitively also. So you need a very simple question that you can ask. And obviously, spirituality is not just the patients, it's also the caregivers, care partner spirituality. I mean, in fact, towards the later stages, it's I think the care partners' spiritual concerns dominate. I find asking that one item question, are you at peace, usually opens up a fair amount of discussion. And the advantage of that is that it is easily translatable into various, I mean, you can use it in any language. It works.
I just have a very, I don't know if you're finished, but I have very interesting data from Australia, where Australian patients feel that this question, are you at peace, means actually, are you dead already? So, so I am not sure what you think about it.
No, I don't think. So in Hindi it is, "Aapke man mein shanti hai kya?" Is your mind at peace? Are you? And it. I mean, whenever I've used it, it evokes.
Yeah, I think it's that theoretically what I have been preaching, it is kind of preaching, isn't it? So I have been preaching that everybody has to find their own question that actually fits with their, like, you have to be authentic. It doesn't have to be something that, oh, here is the question, I have to ask this as well. It is something that which fits with your worldview and your understanding of spirituality. And if you have done a little bit reflection on yourself, and then you know where you are, and then you understand that people can be in a very different place from your take, and then I ask about what gives you power, and this seems to work, or what empowers you, kind of, or what is your source of power, in a way. So in German it seems to work very well, for example. So, but it is also what Christina Buchalski from United States, even though she has proposed some assessment tools, says that even in her very first paper, she said that usually you should find this one question that works for you. Yeah.
So, I mean, it's tossed back to us as practitioners. So
yeah, and then of course the next question to ask is that why I am asking this, and if you are just asking it so that to be done with it, then better not to do it, because it is like a heart surgery in some cases. Some patients pour out their heart and then you ignore them. So here is important moment that I tell to my students that if you decide to ask, then also listen and be really there. So do not fill out some form in a computer or something like that. Then really honestly listen what they are saying and give some cues that I hear you, I see you. And they also have a similar question with patients with in ICU, for example, with whom you cannot communicate. But just this kind of presence that somebody is there, people indeed feel it, and it is important for healing. So that and this is the most difficult thing to teach to healthcare professionals: do nothing, just be. So imagine when we would have healthcare robots to take care of patients' things. So what should a human still do? Just to be there, you know.
So another point that came up in your presentation was support groups. I actually never thought of support groups as a spiritual support.
Churches are a great resource. I think even in India, this is they provide this kind of support groups for example, or religious organizations. Is a big resource also in healthcare, and we shouldn't deny it, even though we want to be very pragmatic and non-religious, I think. And that's why for many caregivers actually go to this kind of group support events if they can, if they think that they have time, and find those helpful. But it depends a little bit on their economic status and their position also, or on their educational status, for example.
No, I was talking of disease-specific support groups. So, for instance, Parkinson's disease, motor neuron disease. Right now, I mean, I am kind of a somewhat passive observer in a WhatsApp group for carers for motor neuron disease, and it seems to work quite well. You pointed out that they no longer feel that they are alone. That's important, and I think we underestimate our own responsibility for nurturing these groups when they start, wherever you are, especially for see, cancer. You make the diagnosis and it's there. There is enough support, but for neurology diseases, for neurodegenerative diseases, sometimes these are rare, and I think it's our responsibility as practitioners to connect them to somebody who says, yes, we are also in the same boat.
Yes, and this is really a great resource. But of course, if you have, I just had an experience with Parkinson's patients who are interested in research, and they have a Facebook group. It's a closed group, so they share all kinds of research on Parkinson's. This weekend, somebody posted there a paper that said that those who are more religious do not fall ill with Parkinson's. and it was an anecdotal evidence on this, which I find awfully difficult. It was a published paper. So now, because this patient sent it to me and said, hey, what's your take on this? So my take was that I spent 3 days of writing to an editor of this journal that this paper should be retracted because this evidence is anecdotal and the statistic is so bad. So our role as researchers and clinicians is also to protect patients with this kind of evidence, which is awful actually, so that this kind of things happen, and even if they go to review process, they still get published. So yeah.
Okay, so there is Ms. Sheila Rathod has asked how to reply when patients ask why me.
Yeah, it is. You don't have to give an answer, honestly. So you have to help them to think why, and just listen to their story. And this usually works quite well. So, and it is absolutely okay, because it is better to just listen and tell me, what do you think? I have good evidence from Israel, where the physicians in palliative care say that they listen. Like if a woman says it's my bad marriage, if a man says it's too much working, and this is a good beginning for a therapeutic relationship. So just listening to their own illness etiology, instead of listing like with 80% of accuracy, we can tell that your illness is caused by this and this and that. So, yeah.
Okay. Somebody suggested that an MDT can help with patient spirituality, and then Ariba has suggested that, are you all right? Facial expressions. I didn't get the rest of that. Teary eyes, yes, I can, but social isolation. Do you want to unmute and ask? Is it a comment or a question?
Ariba, you are muted.
I mixed the two things. The answer to the first one was like to ask whether the patient is all right and feeling good. The second, like to the second question, it was like, how can we see a patient that he's suffering from, like he's having a spiritual problem? For that, I answered like by seeing the facial expressions, he's really like teary eyes, and he's always like he won't smile. And then we can even also feel that we can also ask the attendants whether he's socializing or not, or he has just like cut off from the family and everything, and he's like totally isolated himself. So those patients are more having the spiritual, I have like in my setup, I found those people are more spiritually having problems with, like they are more spiritually down. So that's what I wanted to convey.
Okay. Should we move on to the next topic?
Yes, I think yes. We can take up the questions in the end again. I understand the spirituality is a topic where you can spend a whole, I mean, a few days discussing it, because that is something which we don't discuss routinely. And now we have someone who has done extensive work in spirituality, so there will be a lot of questions. Maybe we can take it towards the end of the.
Yeah, just to end this conversation, because we said that who have more spiritual needs, in my opinion, also people who use humor as a weapon when speaking to doctors actually have usually behind this being very, making fun of their condition, and they seem to be the most fun patients to visit actually, but they can be very, very broken behind this kind of screen of humor as well. And once you get through this, then you can actually start to converse with them.
The sad
but let's
clown.
go on now. Let's go.
Oh yes. So I'll share screen, I think. Right. Just confirm that my screen is seen.
Yes, it is listening.
Okay.
Yes.
So thank you for Pallium India, the whole team there, for getting us in today. And when we speak of neuropalliative care, one of the issues has been that what is neuropalliative care? And I think in the I don't know if any of you were there last year, but I was trying to explain what are the various things we can do. But I thought this time it's easier to kind of broaden the whole thing and take it a little further ahead. So I'm going to, if everybody has a smartphone, I strongly, just give me a minute, I need to check this out. Yeah, okay. So if anybody, I suppose all of you have smartphones. Of course, you can connect with me on the chat also. But I strongly suggest you point your browser at this diagram and connect at slido.com, or you can go to slido.com and enter this number. And what I want you to do is tell me what you think somebody who is into neurology and palliative care can do. One way is I call them neuropalliativists. So let's see if you can tell me. And we'll take a few minutes over this. It won't. In fact, I'm joining it myself. So what is neuropal care? Is it something that only neurologists do, or do you think everybody can do it? Any ideas, anyone? No. Okay, but anyway, Botox, yes. I mean, for severe spasticity, yes, it's a very valid treatment. I'm also going to look at chat if there's anything there. A neurologist work is very different. Deal with neurodegenerative conditions, support patients and caregivers of neurodegenerative diseases. So yes. Any other ideas? Okay, so I'm going to move on and tell you what I think palliative care can give us. Yes, yes, of course. Stop unnecessary interventions. Hope. Okay, so let me move on. So, who does provide neuropalliative care? And remember that at one level, uh, primary or generalist level palliative care can be provided by everyone. This is somebody who continues to practice their basic specialty, incorporates basic palliative care principles into their regular work, and has access to specialist palliative care, which means people who are fully qualified in palliative care for complex issues. For instance, I don't do opioids, and I involve our palliative care physician to help out there. Even end of life care, typically Dr. Jayarajan or Dr. Rajamayyar come in home care, they look after. But the most important thing I'd like to emphasize here is that this need not be a neurologist. Because the reason is that earlier we used to think that neurological concerns were only a small proportion of palliative care needs in the population. But Kerala, and especially the neighborhood networks and the community work there, has shown us that neurological needs in the community are double or triple that of cancer. And you can see that from the records that are coming out, for instance, from Mallapuram. Originally, 90% of the work was cancer. Now only about 20% is. And when you look at the symptoms, they're largely neurological. Of course, care can also be provided by a specialist palliative care physician who works exclusively in palliative care and has an intersectional responsibility. Is there specialist neuropalliative care? Yes. We are now beginning to see, and there are now about 100 of them. Most of them are in the US. These are people who are qualified in both neurology and palliative care. And I'd like to, you'll see more of them as time goes on. Just as an example, Akanksha Sharma is a neuro-oncologist, neurologist, neuro-oncologist, and palliative care. Maisha Robinson is at the Mayo Clinic. She's a neurologist and a palliative care physician, and she runs the palliative care services at Mayo Clinic in Jacksonville. Now, today, the conditions that I'm going to be talking about are somewhat different from what you would think of in terms of degenerative disease. These are life-limiting illnesses that appear in child neurology. So some of them can be static encephalopathy, which means there is a certain amount of brain damage or abnormality that is present, and that continues. It's either perinatal brain damage, brain malformations, chromosomal anomalies, autism. Then there are illnesses which are termed developmental encephalopathy, phakomatosis like tuberous sclerosis and so on. I should have included even people who have spinal cord injury in early childhood and go on with that. They would come in here. Then, of course, there are people who have progressive encephalopathies, a metabolic disease that begins in childhood and the person survives a little later. So leukoencephalopathies, mitochondrial disorders, these are all rare conditions, but cumulatively they are not small. And then there are progressive lower motor neuron syndromes. So you have spinal muscular atrophies and you have muscular dystrophies. And we will talk about them as well. So the common medical themes that you see here are cognitive impairment, which means people can get demented, delirious, they can have behavioral and psychiatric issues, but most importantly, they can lack capacity to make their own decisions. Motor impairment, you can understand, somebody can be paralyzed on one or both sides or just weak, but they can also be ataxic. They can also have extrapyramidal features like Parkinsonism. Then sensory impairment, they can lose vision, hearing, lose sensation in pain, and then they can have fits of various types. And sometimes patients die in status epilepticus. So why do we need this lecture? You can choose 2 or 3, maybe the most relevant statements. Whatever, you just click on whatever you think is important here. And as you on your phone, you can see multiple choices. Uh, let's see what people think are most important here. You can see it on your phone. Right? So, yes, this is probably the most poignant. Parents growing old. The caregiver, the main caretaker, is himself or herself no longer able to manage. Uh, these diseases progress. They're likely to die early, is simple. Children grow up. And as they grow up, they become aware of what their problems are. Psychological issues get worse. The original illness has other complications. All of these issues keep appearing. And who takes care of them? If you say that neurologists are going to take care of them, no, this is not going to be possible. These are all conditions that have too many other issues that come up here. So I'm going to move on now and go on to the rest of my talk. Now, if you look at the way oncology and palliative care have worked, it has been fairly simple. The oncologist makes a diagnosis, gives chemotherapy or surgery, and at some point in time, if the if obviously if the cancer gets cured, there's rehabilitation and survivorship. If there is not, then pain and symptom management become more and more important, and eventually palliative care and bereavement come in. This doesn't work for neurology, and for us, it what we would prefer is what I call the roadmap model for neuropalliative care. The diagnosis is obvious, or sometimes I may make the diagnosis even before the patient has any symptoms. And as the patient goes along with the illness, life events happen, symptoms get worse, disability gets worse, and over a period of time, eventually, obviously, things wind down to the natural. What do we do? As I said earlier, we help with support groups, but what we help more than anything else, and what is most important, our main responsibility is information. They are lay people. They need to know what is happening to them. As you go on, in some conditions, disease modifying therapies can actually produce cures, and more of them are happening now. And with rehabilitation works even when there's survivalship. It also works when somebody is deteriorating. It's necessary. Psychosocial and spiritual support, we've already spoken a bit about that. But if somebody's condition continues to deteriorate, then serious illness conversations need to happen. Advanced care planning needs to happen. In India, we do not have medical aid in dying, but it is there in multiple countries in Europe. For most of our patients, they make choices for life-sustaining therapies if we bring this choice up to them, and then some can choose natural death. Some, of course, go on to life-sustaining therapies at the end of life. And remember, throughout all of this, care partner support is our responsibility. So obviously not as simple as in oncology. So let me quickly take you through some patients and the issues that come up here. The first patient is mine. She's the only child of middle-class parents. She had severe systemic lupus erythematosus causing neurological complications in her teens, residual brain lesions. She was mildly cognitive impaired. She had recurrent seizures. She needed remedial education, but she's doing artwork. And, well, she now gets only occasional breakthrough seizure episodes. And she's now planning marriage. She's very clear, no kids. So when you see somebody with epilepsy, and this is the lowest end of the spectrum, you are looking at somebody who can either have controlled epilepsy, partially controlled epilepsy, as in my patient, or intractable epilepsy. And typically, intractable epilepsy goes with cognitive delay. People who have intractable epilepsy don't survive to old age. They often have learning disability. they have psychiatric symptoms, and they obviously need a great deal of support. And we have to look at taking these patients through adolescence to adulthood. And this is termed transitions, which is the title of my talk. So this is a purposeful planned process that addresses the needs of adolescents and young adults with long-term conditions as they move from child-centered to adult-oriented healthcare systems. This is because pediatric care is family-focused. Parents can be depended on. Typically, medical issues are explained to parents, not the patient. Whereas when you go into adult care, the patient is supposed to look after themselves. And there is going to be a point where even my patient, even though she has a devoted mother, is going to have to look after herself. Of course, there is a point in time when this care is handed over, but and it really depends on the medical system. And a public health system, it will be at the age of 18. Next time they come in, they go into the medicine OPD. So when you do this transition, you have to first start by preparing the youth to understand his or her chronic illness and take responsibility. The patients and caregivers must learn to function independently, and then you identify the appropriate adult healthcare provider, and you communicate effectively with them. If you do it right, then things work out. But probably the simplest and most important thing that you can teach a child or adolescent to start taking responsibility is exemplified here. It's called the My Health 3-sentence summary. This comes from Kids, the hospital in Toronto. And it actually says, like, my patient, this is what I have trained my patient to do. I'm 31 years old. I have epilepsy because of brain damage at the age of 16 years. I tell her, don't talk about SLE, but somebody will get confused. I am getting only minor seizures now. I am on these drugs. And if she goes with something else, often she's worried that she's likely to get a seizure. Just say that. So it takes just these 3 sentences, and she knows to say it. There are various pointers that people include. They say that this discussion has to happen before the 13-year-old birthday. Somewhere along this time, you start figuring out whether this is an individual who will be able to manage themselves. If it is a disease that is likely to worsen or cause more issues, especially if there is an issue of transmission into the next generation, then you need to talk about genetic counseling and reproductive implications. In India, this does not happen, but in Western countries, you need to figure out whether the individual is likely to become legally competent when they turn into adulthood, either age 18 or 21. And if not, we need to talk about legal guardianship. Again, we do not have laws that cover this, but as the parents age, they have to start thinking about this. Ideally, all of this goes into a medical transfer packet, which has all these details. Remember that there are special issues that come up in neurology patients. They are often intellectually disabled as the parents age and die, and the siblings may or may not take care. They are, well, their issues are not known to anybody. Neurologic disorders, I told you about that list of conditions. These disorders can be pretty rare. A pediatric neurologist may have made the diagnosis, but as they go into adulthood, people don't know about them. So one solution is, if they are savvy enough, you put them into support groups, because then they can follow up and see where they are going. Disorders in adult life can change form, and metabolic issues can sometimes end up in adulthood with emergencies that a pediatric neurologist would take for granted, but or a pediatrician would take for granted, but an adult physician would not know about. Ornithine transcarbamylase deficiency, where they produce severe hyperammonemia crisis. Then there may be drugs and treatments that are unfamiliar to adult neurologists, treatments that were disorders that were previously lethal but now have treatment, disorders that require lifelong care. Attention deficit disorder. If you do not pay attention to them, they end up having disastrous lives. And then there are childhood onset disorders which actually worsen in adulthood. Tuberous sclerosis can develop renal failure in adulthood. And And obviously people who come through serious illnesses in childhood, but residual disability is there. So, but what about conditions that will inevitably progress and cause early death? We have to look at those also. And here comes the question of who will look after them. It's usually the pediatrician or the child neurologist who starts off in situations where facilities exist. And I strongly suggest in large cities, you should look for neurologists with subspecialization if these conditions are clearly diagnosed. So you have movement disorder specialists, you have neuromuscular specialists, you have epilepsy specialists. And then they can team up with a palliative care physician and take over. In some academic centers, you may find multidisciplinary clinics for these issues, but obviously that's few and far in between. Or alternatively, you will have to hope for more and more people who are willing to take on these roles, understand the basics of neurological conditions, and be willing to apply a certain amount of palliative care skills. So one more patient. This was my own patient again, a condition called megalencephalic leukodystrophy, which is pretty specific to India. Here they have large heads and the brain develops cysts and degenerates over a period of time. Towards the end of his life, well, this is the story. Youngest and only son, 3 sisters, parents in 70s. Although he was diagnosed at age 8 years, had falls and seizures, no education beyond matriculation. He really started to deteriorate in his 30s. Came in with seizures. He was admitted with us for quite a long time. Eventually, we put in a percutaneous endoscopic gastrostomy. And finally, he died in the vegetative state, but he died in status epilepticus. That quote is from the eldest sister. The eldest sister wasn't married. She lived with the parents, and she was his primary caretaker. This is another patient, Duchenne's muscular dystrophy. Again, resident of a slum. As often happens, it was a single mother. And although he got regular physio and some amount of support by the local dystrophy association, cardiomyopathy came in by the age of 18 years. At the age of 19, congestive heart failure, that was when palliative care came in. And because palliative care had been involved, because the young man had discussed his wishes, in the next crisis admission, no CPR was given and he passed on. And if you look at it, the needs of somebody with a progressive illness like this will change over time, from the diagnostic phase to the supportive phase to the eventual late phase. If you look at DMD, towards the end of their lives, respiratory failure, swallowing problems, and PEG also come up, though my patient did not get it. And you have to look at multiple other medical issues. Cardiomyopathy was obvious, but they can also need treatment for osteoporosis, and spiritual issues will always be there, especially, partly because of, I would say, because of their economic circumstances. He really died early. I have other patients with DMD who have survived into their late 20s and even into their early 30s. But it does take a fair amount of effort and commitment from the family. So the last patient is, he was from Bihar, and at the age of 10 years, psychomotor decline, visual loss, recurrent seizures, myoclonic jerks, ataxia, and Parkinsonian features. You can see a whole panoply of neurological symptoms. Eventually, a movement disorder specialist and movement disorders neurologist diagnosed him as Batten's disease. This is a neuronal ceroid lipofuscinosis, and this was confirmed on genetic testing. He too got a PEG tube and died in the vegetative state. And this is something that comes up again and again in neurology. Dr. Piret also alluded to this, and that is a question of no diagnosis. Remember that in childhood onset conditions, genetic testing is now giving us answers more and more often. And even at a late stage, it is probably important to work towards a diagnosis because it relieves the caregiver's anxiety and they know where they are heading. They can, of course, get into support groups and so on. It also limits further diagnostic testing. In younger ages, it prevents recurrences in family members because you can do prenatal testing. And it gives you long-term prognosis, associated coexistent conditions, recurrent risk, and so on. And if you look at any child who develops this kind of a life-limiting illness, you have so many things to do as they get older. Towards the early stages, you are, if you're looking at quality of life, you're looking at maintaining participation in school and home activities. Then you look at maintenance of ambulation. Then you're looking at maintaining means of communication. Eventually, you're coming down to maintaining comfort. What it needs is psychosocial and transition support for the family. The family has to be educated. Ideally, a palliative care team, either somebody from who has a neurologist with palliative care training or a general palliative care team, should come in. Home nursing and connection and advocacy and other support services help. If possible, a multidisciplinary team can help with symptom management. And there are multiple symptoms, as you can see in the last patient. Nutritional care is important. If need be, interventional therapies like speech and feeding or a peg tube, looking at complications, and general pediatric care all come in. And towards the end of life, what you need are early and frequent discussions with the family. Again, home palliative care, and then finally grief support and counseling. So this is the whole journey of patients like this. And again, unlike cancer, where you are only dealing with provision of morphine and at the most some other limited symptoms, here you have a whole panoply of drugs to use. And it is important when you are giving this kind of a complex cocktail of medicines. Of course, towards the end, these drugs come down. Then it's important for somebody to be looking at the interactions of these medicines also, because they can end up with complications there. What I suggest is that if there are questions, we can take questions both in the chat as well as on Slido, and I'll be happy to answer them.
I think there are no questions in the chat. If anyone wants to unmute and talk, we can take up one or two questions before we go on to the case presentation. If there are no pressing questions, maybe we can go ahead with the case presentation.
There was one in Slido. How can we support a 22-year-old patient with neurofibromatosis type 2? Okay. I think the most important thing issue at that stage will be regular screening, because there's a fair amount of issues that crop up as they get older. Does anybody want to ask this personally? Anyway, you can also communicate with me, and I can pass you. If there's a personal issue, I'm happy to answer this on email and give you the relevant literature. We can move on to the case. I'll stop sharing.
Yeah. Yes.
Okay. Sure. Let's go on.
Yes, Dr. Naina, please.
Good evening, everyone. I'm Dr. Naina Mary Francis. I'm working as a junior palliative care physician in Palliative, India. So today, I'll be presenting the case of a 54-year-old male patient who was diagnosed with left hemiparesis, right NCA stroke, with systemic hypertension and type 2 diabetes mellitus. So patient came with the complaints of pain over the left lower limb extending from hip to the knee region since last 1 month. Pain is intermittent in nature. Pain score was 5/10 during rest, and the pain worsens to 10/10 during movements. That's not walking, it's during movements. The quality of pain is pricking type. The pain is so severe that he is not able to lie down on both sides due to pain. Also, he is not able to sit even with support for a short time due to pain. Other complaints were constipation. Bowel moves only once in 3 days. That too, it was hard stools. For bladder, he was using urinals. Sleep was also reduced due to pain. And initially he was on physiotherapy, but due to the pain, he discontinued physiotherapy. Next slide. Okay, now coming to the history of illness, patient was in his usual state of health till last February when he developed headache and abdominal pain when he was diagnosed with hypertension and he was started on with antihypertensives. He was on regular medication, and a month after which he developed a sudden onset of weakness of both left upper and lower limbs while he was going to the washroom. He also had a fall following the weakness, but there was no history of any injury. He also noticed a slurring of speech and deviation of angle of mouth to right side. He was taken to the nearby hospital, from where he was referred to Medical College Hospital, Trivandrum. From there, CT scan was done, and it was diagnosed as acute infarct. CT angiogram was also done. It showed that complete luminal thrombosis of the segment, and thrombolysis was done on the same day with tenecteplase. During hospital stay, he developed LRTI and he was managed conservatively with antibiotics. Physiotherapy started and he got discharged from the hospital after 7 days. Initially, patient was doing physiotherapy, but since last 1 month, because of the pain, he was not able to do it. He discontinued it. Next slide. So during our examination, we found that he's conscious, oriented, he's well built and nourished. Oral cavity, skin and pupils are within normal limit. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, nothing is there. CNS examination, power of right upper and lower limb is 5/5, but power of left upper limb is 2/5 and lower limb is 1/5. Other systems were within normal limit. Next slide. So treatment and significant investigation. CT was done and it showed acute infarct, right MCA territory involving frontal, parietal, and temporal region. Hypodensity in the bilateral capsuloganglionic region. Chronic lacunar infarct, bilateral capsuloganglionic region. CT angiogram showed complete luminal thrombosis involving right CC and ICA segment. Thrombolysis was done on the same day. And for lower respiratory tract injection, he was given injection piptas for 7 days. And he was discharged with advice from Medical College Hospital with ecospirin, Pantof, Tab Envas, Atorva, Metformin, and he was asked to continue physiotherapy. Next slide. About the psychosocial aspects of the patient. Patient was a government employee. He's a government employee. He was working as a telephone attendant in a water authority. After the stroke event, he's not going for work. He says that the only thing which is concerning him is a pain. He also said that he's confident that he'll improve once his pain comes down and once physiotherapy is restarted. He also added that since he's a government employee, he'll receive his salary and he has all bill reimbursement and he has leave till September. The concerned patient is his wife. She is very supportive, but she's very anxious about the prognosis of the patient. She said that she is not sure whether patient will be able to go for work like before and whether he'll be able to walk again. She also has that physical difficulty that she's not able to lift him or shift him because she has become physically weak now. She has also loss of sleep now and because she's worried about the future. He has 2 children, a boy and a girl. Boy is 14 years old and girl is 11 years old. Both of them are currently staying in a relative's house. So they are not able to go to school now since school is far away from relative's house. These are the psychosocial aspects. After coming to Palliative, he's currently admitted there. So we have started him on tramadol Q6 daily, tap paracetamol 500 mg Q6 daily, and ecospirin, pantoprazole, enalapril, atorvastatin, metformin, bisacodyl, and crimafin. So his main concerns are patient is not able to continue physiotherapy due to pain, and wife is a primary caregiver. She is having caregiver fatigue. Physically, she is not well. Then children's currently staying in a relative's house. They are not able to attend the classes. Caregiver is anxious about the prognosis of patient. Patient is 100% confident that he'll be able to walk like before when physiotherapy is restarted. Next slide. So the summary is 54-year-old male patient who is a non-case of left hemiparesis, right MCA stroke thrombolized on 21st March, who was regularly doing physiotherapy, developed pain since last 1 month, discontinued physio, came to Palliative for physio rehabilitation. So discussion points are pain in stroke patients and role of opioids, role of palliative care in stroke patients. And as a palliative care team, how do we prognosticate recovery in stroke patients? During hypertensive emergency or urgency, when do we need to refer patients to higher center? And caregiver fatigue in neuro patients. That's all. Thank you.
Thank you. Thank you so much, Dr. Naina. I could see Roop's smile whenever the medications were going on. And this is actually something we deal with every day in our setting for others to understand. We have a neuro palliative care, especially for stroke patients. And these are the areas our doctors get stuck most of the times, especially the prognostication, the pain, opioids, and optimizing the existing medications that they are on. And very importantly, caregiver fatigue and the hope. So I would open this for Roop as well as Paal for your inputs on this.
Piret, can I take
Yes,
this
please.
on?
Yes, please.
Okay. So as far as pain management is concerned, I would explore the use of, say, something like gabapentin, pregabalin. Fortunately, in India, it is not that expensive. In addition to tramadol, see if that helps. A fair amount of the pain could be due to spasticity also. So I'm not sure if it is possible to, but we could use drugs like Liofen. If need be, we could even go on to baclofen and so on. But of course, one of the advantages of pregabalin and tricyclic antidepressants, and because one question is, was he assessed for depression, even though he insisted he was well? What I didn't notice was he assessed for depression? So somebody asked, what is the reason for pain in stroke patients? There are multiple reasons. At the central level, it could be thalamic involvement. At the lower levels, it could be spasticity, lack of mobility, so musculoskeletal causes, and it can be quite bad. And the management is it's never usually just one thing that works. So I think that depending on tramadol alone may not be a very good idea. So I think we should try out gabapentinoids. I usually prefer pregabalin, and you don't need them for very long periods. Okay, so that's one part of it. Does anybody think that that's all that Palliative India is going to be doing? So
I think rather than medications, I'm sure Naina would also agree. It must be a lot of conversations happening day in and day out. I'm just guessing. Maybe she'll be able to speak more about it.
SNRIs, somebody suggested SNRIs. Yes, but for neuropathic pain, tricyclics are probably better than SNRIs. Palliative care in stroke patients, yes, there's a huge role. I mean, you have to address, starting from uncertainty initially to go on to prognostication, to go on to recovery of function, the worry about future strokes, all of that needs to be addressed. Prognostication, ideally, this is done as a combination of the clinical examination as well as the area of damage on the MRI. So typically, most of these patients would have had a CT scan or an MRI, and that shows you the amount of damage. And together with that, you also know about that from the clinical presentation. So if the clinical presentation shows you that somebody has not just hemiplegia and spasticity, but also sensory loss on that side, and maybe even visual impairment or inattention on that side in that hemifield, then this is a pretty large stroke. And this is somebody who will have problems. And usually right hemispheric strokes cause much more psychological issues as compared to left hemispheric strokes. Piret, any suggestions, anything to be?
Yes, as all this kind of medical advices come in and suggestions how even until the full recovery, we still have to consider some things here. And one thing that I mentioned already is this kind of having a good initial talk. Coming back to that also that the caregiver is present and the patient is present, and maybe not immediately after the stroke, but now already some time has passed and this patient is in palliative care or receives palliative care, then to have this initial talk, what to expect. And in stroke, it's really, there are things you can expect, and it can also end up really when we are very optimistic with full recovery, but still patients who have had stroke have this, okay, yes, but I saw one comment there that, so, as physicians, you have to hope for even for that you can cure everything. But yes, so you have to think that this patient will never be the same because the fear and the anxiety will remain in his system, that this can happen again. And it remains also in the family. And now what we have there, we have a wife who is overwhelmed, and there is this term in palliative care which is called respite care. So this is kind of retreat for caregivers. It can be, for example, just sleeplessness, so that we also ask for this. Okay, so you are exhausted all the time, you cannot sleep. And so to offer to the caregivers this kind of respite care, which means that they can be removed from the carer's role at least for a while, so that they can gather some energy and continue doing this. In this case also there is a strong indication, even though the word is not used, is of anticipatory grief. So what happens if my husband is not going to work again? This is socio-economical worry also. And a special thing, because we had a talk about the young adolescents here, the children, getting back to normal life, that the children can go to school, they can see what is happening to their parents so that they are not removed from this stressful situation. Informing school, for example, that family is in this kind of distress. And something that nobody really wants to do is to talk with children about the situation, because nobody really feels responsible to initiate a talk with children, honest talk with children as well. And I think that in particular now, when we look at this age group, not to give too much information, but children have to be on board, because afterwards, if they are not involved, there are so many issues with grief and bereavement. For example, if their father dies, and they just have been living with relatives, not going to school, and not seeing the father also like declining, can cause lots of problems also later in life. And it is healthcare professionals' role. But some nurse told me that it is like a can of worms that nobody wants to open. So this is really so complicated issues, talking to children. So nobody feels really responsible of doing it. So these are my concerns here, very psychosocial and so on. Yes.
Thank you, Pal. I think those are very, I was just asking Dr. Naina also, the patient is just 2 days into palliative care. So probably these are the things which we can do in the coming days that this will definitely give a direction to the clinical team how to have those conversations.
Is this patient there right now?
Yes.
So one thing that I see, he was a telephone attender and his stroke is on the non-dominant side. I'm absolutely sure he can go back to work. I mean, once his pain and motor issues are partly taken care of. So maybe it's a good idea to reassure him about that. With the social worker, that should be possible.
Hello. Can I ask
Yeah.
a question? Dr. Roop.
Yes, go ahead.
Good evening, Dr. Paal. If there is thrombosis and the thrombosis was thrombolized, so it should recover fully. What do you think?
No. It was occluded.
Thrombosis.
Yeah, but it was occluded. So very often the occlusion is long-standing. It doesn't respond to intravenous thrombolysis.
I thought it is only thrombosis actually.
No.
Because thrombosis usually recovers.
Yeah,
thrombosis, they do recover.
but not always.
This is occluded because of what? Thrombus? Not always.
Quite possible. Right.
It's just, there is another question in the chat about tramadol in patients with neurological issues, like in terms of seizure threshold. So, Dr. Meenakshi is asking your comments on that.
So, I think for one thing, that would be an individual risk assessment. And this patient, if there is no prior history of epilepsy, he's not had any seizures during this illness, I think that is probably a low risk. We don't need to worry too much about it. My main concern is it necessary? For one thing, the pain on the pain ladder, he was at 5/10. Is it appropriate to? And it is more neuropathic. I mean, the features seem more neuropathic. So, would we prefer alternatives to opioids, even weak opioids?
Dr. Naina, is there any other question or from the participants? Is there any other questions that that is not being answered? There is a comment from Dr. Shashikala. Maybe the problem of his children is causing him some of the pain. Very, very, very true.
Quite right.
Paal was mentioning. Yeah, I think dealing with children is very important here. Especially they are away from the family and they are not able to go to school. That's also that might be another point of worry for the caregiver, because unable to take care of children and be with the husband, unable to
How
do the
would
role
you
properly.
How would you handle it, Piret? I mean, you would handle it as a family discussion with the kids also there, the wife, the kids, the patient, talk to all of them together at one time.
Yes,
And
and also involving, we would have then this kind of intervention for the family and social worker. And here is very important to inform the school, of course, so that the school can also understand what kind of situation the children are, because the children maybe act very well at home, but they act differently at school, and then teachers don't understand what is the reason for that. And so that usually then And therefore, it is important to inform also the teachers about the situation. And then, yes, this kind of father's anxiety, it is socio-economical, and it is, yes, of course, not being able to see the children. Also, this kind of existential fear of what is if my life ends, or also that this might be not be the biggest concern. The concern is what is if I cannot go to work, actually. So that is on the top of everything, and and then so this is also something that social worker usually, at least in Europe, can help with, and think that what other solutions are there. And then, yes, this being worried about family members is one thing that can cause also spiritual pain, or be part of this total pain concept, so that you are worried about the others and cannot help them in their grief, which is at this case anticipatory. And yes, so there also a good talk would be good. And usually it is like this, that you have to knock on the door, and who from the palliative care team then can open the door remains to be seen, kind of. But you have to at least tell that we can offer this and that and those things. And then at some point, maybe patient picks up on this, or the caregiver as well.
So actually, that was a point that I think we all missed. Thanks, Piret, for pointing out that we didn't pick up on the spiritual pain in all of this. Yeah, so it'd be interesting to see how much it changes from 5 or 10 if all of that is addressed.
Yeah, very true. There are 2 more questions in the chat before winding up. Can we use TENS for pain control, and how to manage pain due to thalamic stroke?
TENS is used, but it has a huge placebo effect, as far as I can make out. So, and it's not always available. The second is pain due to thalamic stroke is bad. I mean, typically, it's not so bad in infarcts, but if somebody has a intracerebral hemorrhage in the thalamus, it can cause trouble for decades. It's very difficult to treat. It doesn't respond to any kind of thalamotomy or surgical procedures. Nothing. It's really very troublesome. It does respond to the same kind of drugs that you use for neuropathic pain. So I've used carbamazepine, I've used pregabalin, but it can cause a long-standing problem.
Thank you so much. I think we've taken all the questions in the chat, hopefully. Yeah. So thank you so much, all the participants, for the interaction. And I must say there was a lot of learning. And I think Dr. Paal has a lot of work to do in India in terms of spirituality, spiritual care, because it's like a huge area that needs, as a physician ourselves, we need to be very clear about the religion and the spirituality, and unbiased towards patients. That is something where we should start with. But yeah, there is a lot of work to be done. We talk about the spiritual pain, but as you said, we are still not equipped to touch upon that area, because many times we don't know how to deal with that once you open the can. So this was a very, very good message that we got today, and hopefully we can talk about this more sometime in future. If you are willing to teach us more about it, we're happy to have more sessions from you. And thank you, Dr. Roop, for as usual, you bring in a lot of new perspectives during each session. So this is again different from what we usually talk in neuropalliative care. So I felt it is totally new. Many things are new, and yeah. I hope all the participants also had a lot of learning from today's session. And thank you so much, both of you, for being present here. Thank you all the participants for interaction.
Bye, Piret.